Good afternoon, dear students. I am assistant of Physiopulmonology department, Mayseenko V.I. Topic of our lecture today is one of the most important occupational diseases from exposure to industrial dust is pneumoconioses. Content of our lecture you can see on this slide. At first, we start from classification of industrial dust. First, classification on nature, organic and inorganic. Second, on particle size, fine dispersed with size of particles less than 0.1 microns, average dispersed with size of particles from 0.1 up to 10 microns, is most dangerous as easily and deeply gets into lungs but is difficultly deduced with Lyme at cough, and large dispersed with size of particles more than 10 microns. And third, on way of formation and aerosol of decomposition and aerosol of condensation. What pneumoconiosis? What does this mean? Definition from is the accumulation of dust in the lungs and the tissue reaction to its presence. Pneumoconiosis is a group of interstitial diseases caused by inhalation of certain dust and the lung tissue reaction to the dust. There is a long delay, up to 10 years or more, between exposure and onset of disease. You see epidemiology of pneumoconiosis in different countries. First place is Vietnam, second is China and Korea, and other countries. Pathogenesis of silicosis depends from dust particles and other factors. Dust within the size range of 0.5 to 3 micron pose maximum risk as this can easily enter the alveoli. Particles larger than 3 microns don't reach the alveoli. Particles smaller than 0.5 microns are exhaled out. The dust particle which can deposit in the alveoli cause inflammation in the lungs that can eventually lead to fibrosis of the lung tissue. In addition to causing fibrosis, the deposition of dust also leads to reduced ciliary clearance. The chemical composition may be cytotoxic. Some dust may cause more fibrosis than others. For example, silica dust can lead fibrosis after several months of exposure. Coal appears to be relatively inert and may accumulate in sizable amounts with minimal tissue response. The pulmonary alveolar macrophage is a key cellular element in the initiation and preparation of lung injury and fibrosis. The more reactive particles trigger the macrophage to release a number of products that mediate an inflammatory response and initiate fibroblast proliferation and collagen deposition. The specific types of pneumoconiosis are named by the substance inhaled. For example, coal dust causes anthracosis, silica dust causes silicosis, iron siderosis, organic dust, the second name, hypersensitive pneumoconiosis. For example, cotton dust causes bicinnosis and others. Factors affecting the development of disease: chemical composition of dust particles, size of dust particles, concentration of dust in atmosphere, duration of exposure, individual susceptibility of health status of the person exposed. Pneumoconiosis usually takes years to develop and may progress even after the exposure has discontinued. The main classification of pneumoconiosis is two main types: fibrogenic or true pneumoconiosis and non-fibrogenic or benign pneumoconiosis. The main types of fibrogenic pneumoconiosis is asbestosis, silicosis, coal workers pneumoconiosis, and other rare forms of pneumoconiosis: it heart metal disease, aluminium fibrosis, berylliosis, talcosis, and others. Non-fibrogenic causes only by iron, barium, boric acid, manganese, titanium, and bismuth. Main symptoms of pneumoconiosis on early stage is symptoms may not be easily noticed. Later stage is cough, chest tightness, shortness of breath, and fatigue. The impact and severity of pneumoconiosis depend on the type of dust, how much of the lungs are affected, and how intense the dust exposure was. In some cases, pneumoconiosis can be very severe and cause death. Diagnosis based on medical examination, on chest X-ray, and pulmonary function test. There are 3 stages of pneumoconiosis: first, second, and third. The main criterion for the staging and the radiological signs, though they also pay attention to the data of the clinical presentation and functional examination. First stage of pneumoconiosis proceeds with the relatively small expressed clinical signs and the more significant radiological changes: bilateral diffuse enhancement and deformation of the pulmonary pattern, moderate compaction, and structural changes in the roots of the lungs. Small number of fine spotted shadows, 1 to 5 millimeters, in the lower and middle parts of the lungs. And the interlobular pleura of the right is often synced. Second stage is characterized by more pronounced clinical symptoms, impairment of the external respiratory function, and development of complications. Pronounced stressing and deformation of the pulmonary pattern, a large number of nodular shadows up to 3 to 10 millimeters. The roots are widened, densified, take off a chopped off appearance. Pleura is synced and deformed, like on this slide. And third stage of pneumoconiosis is accompanied by frank respiratory symptoms, signs of pulmonary and cardiac failure. The signs of frank pneumofibrosis, interstitial, nodular, or not, like in this case, are detected. General treatment. Pneumoconiosis is incurable. No specific treatments or medication for it. Current treatments for patients are aimed at limiting further damage to the lungs, reducing symptom severity, and improving quality of life. The doctor may prescribe medicine that are inhaled to reduce inflammation in the airways and to help keep the bronchial tubes open. Most common is broncholytics, for example, salbutamol or ipratropium bromide. If the oxygen level in patient is below 90%, home oxygen therapy may be administered. Also, the doctor may recommend immunization with the influenza and pneumococcal vaccines. Now also coronavirus vaccine. If symptoms of respiratory infection are developed, antibiotics may be required. And now, one of the most popular form of pneumoconiosis is silicosis. Is most common pneumoconiosis involved occupational exposure to crystalline silica. Silicosis, also known as Grinder's disease or Potter's rot. Silica dust is the most abundant mineral on the earth and high risk rate for crystalline silica exposures, tunneling, hard rock mining, sandblasting, foundry work, ceramics work, brick making, paint making, polishing, stone drilling, well drilling, and other works. Silica-induced disease, chronic bronchitis, emphysema, silicosis, tuberculosis, lung cancer, collagen vascular disease, and immune-related disease, progressive system sclerosis, and rheumatoid arthritis, or second name Kaplan's disease, sometimes chronic renal disease. Depends on exposure, intensity, and quartz content of dust, divided in chronic simple or classic silicosis, chronic complicated silicosis, accelerated silicosis, and acute silicosis. The induction period between initial silica exposure and development of radiographically detectable is usually more than 10 years. In case of acute silicosis, within 6 months to 2 years following massive silica exposure. Simple silicosis. Its most common form after 10 to 20 years of exposure with silica dust, almost without symptoms. Sometimes patients suffer from breathlessness, dyspnea initially with exercise, and cough with or without sputum. In case of auscultation, often normal but may arouse or decreased breath sound. On X-ray, nodules and scarring form in the lung, rounded opacities about 1 or 10 millimeters, sometimes with eggshell calcification of lymph nodes. Pulmonary function test often normal but may restrictive, mainly obstructive or mixed pattern. Patient often asymptomatic, seen for other reasons, and divided into simple and after complicated or complicated form of silicosis. On this slide you see simple form of silicosis with rounded opacities about several millimeters, less than 10 millimeters, in both lungs, most common in upper and medial part of both lungs. Accelerated silicosis. Time from exposure to X-ray changes and changes on pulmonary function test is much shorter. Moderate high exposure to silica with 40 to 70% quartz. Elation period between 2 to 5 years old from exposure to presentation, and rapid progression to progressive massive fibrosis. On this slide you see CT scan patient with progressive massive fibrosis in both lungs. On this stage, patients suffer from cough, external dyspnea to respiratory failure. In case of auscultation, decreased respiratory sounds. On X-ray, round opacities more than 10 millimeters. Acute silicosis, or second name silicoproteinosis. Short duration and high concentration of silica dust. Most common it's tunneling, abrasive blasting, and other works. Latent period few months to 3 years after exposure. Symptoms. First symptoms is rapidly progressive dyspnea, crackles in case of auscultation of patient. On X-ray, diffuse peripheral alveolar filling, consolidation, A type of alveolar proteinosis. On CT scan, it's ground glass opacities, pulmonary function tends progressive restrictive impairment, and unfortunately this form fatal after 1 or 2 years. On this slide is CT scan and X-ray, chest X-ray patient with silicoproteinosis. Diagnosis based on history of silica exposure that sufficient to cause this illness, chest radiograph features consistent with silicosis, and absence of other illness that mimic silicosis. World Health Organization recommendation X-ray and spirometry at baseline all people who worked with industrial dust, and then after 2 or 3 years of exposure, spirometry and X-ray. Associated illness with silicosis. First at all, it's mycobacterial infection, lung cancer, connective tissue disease or Kaplan syndrome when we find rheumatoid arthritis and silicosis, renal disease, and silicosis lesions. For this disease, first place of treatment is prevention to this disease, engineering intervention, administrative controls, and respiratory protective devices. On this slide you see respiratory protective devices, other of these forms, and on this slide is example of a combination of measure controls. Sandblaster using proper respiratory protection inside a ventilated bath. Note that the worker is supplied with 2 separate air lines, one to supply fresh air to the worker to breathe and the other to supply air for sandblasting. Treatment: corticosteroid with isoniazid in case of acute silicosis or TB and silicosis, lung lavage and lung transplant in case of silicoproteinosis or rapidly progression of silicosis. On this slide, typical radiographic characteristic of other forms of pneumoconiosis. In case of coal dust, beryllium, talc, silica dust, hard metal, cobalt, and asbestos. For development and to stop progressive disease from exposure industrial dust, we need to discuss limitation of work-related exposure to dust. It's based dust control and dust monitoring. Dust control, the primary objective of employment control measures is to prevent harmful exposures that might result in occupational diseases caused by breathing air contaminated with harmful dust, fogs, gases, smoke, sprays, or vapors. This is accomplished as far as possible by accepted administrative and engineering control measures. When effective engineering controls are not feasible, or while they are being instituted, respiratory protection may be required. Engineering controls: substitution of process by wetting the workplace or workplace with water or surfactant to limit dust generation. Substitution of materials, physical form. Substitution of process by wetting the workpieces or workplace with water or surfactant to limit the dust generation. Ventilation: ensuring adequate ventilation is the most commonly used engineering control strategy. Housekeeping and maintenance: the workplace should be cleaned regularly to prevent accumulation of dust and secondary dust formation. Administrative controls: work scheduling could limit the workers working in highly populated environment to set up arrangements for additional control measures when the dust level at the workplace reaches the present action level. Personal protective equipment includes shelters, protective clothing, respirators, and goggles. Training is required for workers to use the protective equipment properly. And dust monitoring. Measuring helps to assess the exposure level, evaluate the effectiveness of the control measures, and record the information for academic studies. And the last slide, and implementation of personal protective measures, information only for your patient. thank you for your present. See you later.